Good afternoon, everyone. If I can have your attention, please, we're going to get started. My name is Brian Leland. I'm the Associate Program Director of our Clinical Ethics Fellowship at the Fairbanks Center for Medical Ethics and a pediatric intensivist, and I have the pleasure of introducing our panel for today's discussion on medical marijuana use in Indiana, navigating the hazy scientific, legal, and ethical conundrums. I'm going to introduce our guests from your left to right. Perfect. So first we have Dr. Kurt Patterson, who is a family medicine physician with IU in the Department of Family Medicine, and he is co-chair of our of the IU Health Ethics Committee. Thank you for being here. Next is Dr. Sage Arbor, who is assistant professor of biochemistry at Marian University College of Osteopathic Medicine, and his primary areas of teaching and research involve biochemistry, pharmacology, and drug design. Next is Dr. Paul Helft. Dr. Helft's a professor of medicine in the Division of Hematology Oncology and is the director of the Fairbanks Center for Medical Ethics. And last but certainly not least is Tory Castor. Tory is Senior Vice President of Government Affairs for Indiana University Health, and in this role, she directs IU Health's legislative and regulatory advocacy efforts. I will remind everyone, if you'd be so kind, as to silence cell phones and pagers, and a special thanks to the IU Health Risk Retention Group for providing all of our lunches today. No, all future lectures will not have lunch provided, but now that we know how many people should be here on a regular basis, we do expect you to continue to attend. This lecture is being broadcast, so a special thanks to everyone joining us from Ball and West and North and Arnett and Blackford. And importantly, none of our panelists have any financial conflict of interest to report. So without further ado, the lecture presentation will be a series of presentations by each of our panel experts, and then they will have a time for Q&A, and we're grateful that they're here. Oh, I did forget one thing. I apologize. Your evaluations are online, which is in a little blue card that you should have grabbed when you got your food this morning. Thank you very much.
All right, everyone. I'm going to quickly go over some of the mechanisms of how marijuana affects our brain and the legality on what is being legalized in different states and how that actually different components in the marijuana plant affect things differently. So if you're talking about edibles versus smoking versus vaping versus a hemp plant, there's different chemical components in there. So a quick summary of how neurons normally work. Normally you have your presynaptic neuron over here. Dopamine can come out and it can bind your dopamine receptor in the postsynaptic neuron. There's this inhibitory mechanism where GABA can bind a GABA receptor and basically shut that off. Why am I telling all of you this? Because marijuana, or specifically the compound THC, which you've heard about, I'm sure, in marijuana, can bind the cannabinoid receptor CB1. There's actually two cannabinoid receptors, CB1 and CB2. CB1 is the main one that most people talk about. So THC binds there and blocks GABA, and so can increase the dopamine. So there's a few things to say here briefly. One, this is a little different than other drugs that work in our brain. A lot of them work by blocking reuptake of dopamine and neurotransmitters, so it builds up in the synaptic cleft. You're actually inhibiting an inhibitor, and there's a little kind of minutia difference of how that plays out in our brain. In addition, we have endocannabinoids, things like marijuana that our body makes ourselves, and it's made in the postsynaptic neuron, floats back and binds this receptor on its own. So we're just mimicking a natural compound through the use of THC. In addition, other compounds in THC can directly bind the serotonin receptor. So that's a different thing, and we'll talk about what's binding there. So this has a lot of numbers you don't need to worry about. The main thing I want you to get is that in the marijuana plant, there's this biosynthetic pathway that lead to these two compounds which are very similar, THC and CBD, cannabidiol. So CBD is that thing that bound the serotonin receptor that I told you about earlier. THC is what everyone thinks about that causes those kind of movie-like symptoms of a general pot smoke or marijuana use. And different plants have different ratios of CBD and THC. And so in some states, you can legalize a plant that doesn't have a lot of THC. And so there are CBD type plants or THC type plants or hybrid plants. Okay, and the difference in the amount of THC, which is what most people are going out and trying to find these variants that are really high in THC, the difference in the content of THC can be 20-fold between these different variants. So you can imagine if you're in a state, which we are not, we are one of the last states that is in no way has legalized marijuana, Indiana, but if you're in a state that does have it, what is someone growing in their house or what are they getting? The potency of what they could be getting could vary 20-fold. Likely they're not trying to smoke a hemp plant, but that is out there. And then in the next slide, I'm going to go over most of the data of what is known about efficacy, and it's from this National Academy report that came out this year in January. And as of that report, actually, that was a draft report. The final report came out yesterday. As of that report, 28 states had legalized medicinal marijuana and 8 states had recreational marijuana laws. I'd point out that depending on how you define medicinal marijuana legality, some people will say it's as high as 44 states. So there are some states where it's legal, but there's no legal way to produce it or buy it or use it, or use it in a lot of places. And so those functionally are not states where you can use it. All right, so this is a little complicated because this report, which the reference, I didn't know if you were going to have these PowerPoints, is right here. It's a free report you can get. Summarizes hundreds of primary literature articles. But in short, in the middle of this slide will be things that we don't have evidence on. We don't know if it works or if it doesn't work. On the right, I'm going to talk about things that we have strong data that things are statistically associated. And on the left are things that we have strong data that are not statistically associated. So on the left and right, we actually know what's going on, and in the middle, we don't. And I've boxed everything bad in red and everything good in green. So, sorry for the colorblind people. So I'll say it in words. So on the bad side, we do have strong evidence that marijuana use, and most of this data, honestly, is about heavy marijuana use, can cause bronchitis. It can cause psychosis and schizophrenia. It can cause pregnant women to have babies that are small for gestational age. And there's actually a large preponderance of traffic accidents of heavy marijuana users. So a lot of the deaths associated with marijuana use are due to traffic accidents. So now we're down into the intermediate amount of data, but there's still a fair amount of data that heavy marijuana use increases suicide. It acutely affects learning. So if you are heavily using marijuana and then studying for a test, you will not learn as well in the short term. FYI. All right. It actually can have overdosing effects, especially for children, and that's largely due to the edibles. So if you inhale THC or marijuana, the effect is very fast and people tend to stop because they get their high. If you eat an edible, it can take hours, 2 hours to take on effect. So they end up consuming a lot more because they haven't had their effect yet. And in addition, edibles are being found in houses and children are getting large doses. So that's a problem. And there are positive and negative respiratory effects. So it can hurt, you can have positive pulmonary dynamics and positive and negative respiratory effects. I'm not going to go over a lot of the stuff that we don't have a lot of information about. There's some data, that there's testicular cancer associated. It's linked with prediabetes, but it's linked against actual diabetes. It seems to help with head trauma. If you have a head trauma and then have marijuana, it seems to help. There's no evidence that it affects the development of PTSD. There's a ton of research about PTSD. There's no evidence that marijuana use affects all-cause mortality. And it doesn't increase heart attacks. but here it increases the triggering of heart attacks. So the minutia kind of needs to be flushed out for a lot of those things. Interestingly, there's strong data that it is not associated with worsening psychoses, and it's actually not associated with head and neck cancer, which is very surprising to most. I think that's probably because of the frequency of smoking compared to chain smoking cigarettes. But you can imagine if we get down the line and things get legalized more, you could even have filters on marijuana cigarettes that are not there now. But anyway, there's strong evidence it's not for that now. Okay, and so now the things that the lay public most knows, now I'm going to talk about how can we actually use this. The top was all associations. Now the bottom is evidence. What do we have evidence that I can prescribe this for and it works? It works for a variety of pain, right? So that's one of the most well-known things. Marijuana can help with a variety of pain. It also works for anti-nausea. So cancer patients are often nauseous from chemo, and it can help them want to eat and maintain weight. And it helps with seizures. So it's been used for a variety of seizures. So if you ask patients of multiple sclerosis, there's strong evidence that it helps with their seizures. It also helps with sleep. The PTSD here should actually be read, but it doesn't seem to help with it does help slightly with social anxiety. Again, appetite for HIV patients with Tourette's. If you ask doctors of multiple sclerosis patients, does it help with their seizures? It helps, but it's not as statistically significant. And PTSD is kind of up in the air. It doesn't seem to help for glaucoma. It doesn't help for pain of multiple sclerosis, not seizures. And it doesn't seem to help with dementia. Okay? And then there's a ton of cancers and other things that we still don't know, and there's not enough evidence. That doesn't mean it doesn't help. It just means we don't know. All right. And lastly, I just wanted to show you quickly what's the harm ratio of cannabis. So here's cannabis in the middle. Red is harm to others. Blue is harm to the user. And it's basically much less than the opioid epidemic. So last weekend, I was actually driving to DC and I passed through West Virginia, and they are currently passing legalized medical marijuana at the same time that they are passing laws to help the opioid epidemic. So generally across the country, states are moving in the direction of, okay, marijuana is not so bad, opioid addiction is a huge problem, and laws addressing both of those are happening. And then here's an graph from the same thing showing the split up of what causes harm in these various things. And again, cannabis, like I said, it has some negative psychoses and some positives, and the degree of dosing matters in what you're taking. So there's a lot of lack of information out there, and we'll get into how you're going to deal with it in a state where it's not legal. I think that's all I have. Oh, and then I won't go into this, but this is kind of a flow chart of ethically, what do we have to think about here? Is something safe? If it's not, you just make it illegal. Now we're in this realm where marijuana is useful for some things. What's it effective for? And then how do you control it? Can you grow it at home? Is it over the counter? Is it prescription? So marijuana currently is a federal Schedule Class 1 drug. That is reserved for, there is no use for this. No one should ever take this. It never helps anyone. So other Schedule 1 drugs are LSD and heroin. So that likely won't last. 10 years from now, I don't think it will be a Schedule 1 drug, but there's a discrepancy between it is federally illegal and now it is legal in most states. And so what do you do with that? If you are a distributor of marijuana in a state, you actually have to pay tax on that. The federal government says even if you do something illegal, you have to pay taxes. But they can't get a bank account because the bank would be laundering their money. So this is why they do all their business in cash, and they actually pay taxes in cash. And so there's all these ramifications economically as well as for your doctors. So I'll turn it over there.
Yes.
Should we just close it down a little bit?
So I don't have fancy slides. I'm here to tell a few stories and prompt questions. So this is my view from the primary care world as a family doc and what a lot of us are seeing in the outpatient world. And I think there's a distinction to some degree between what we think about with medications, pain medications, marijuana, how we manage that, in hospitalized patients versus then when they roll into my office and I get to hold on to them and manage them for the next 6 months to a year and keep them out of the hospital. So I think where we're seeing the complexity around these issues are, yes, there's this data about some safety with marijuana and some good. There's some clear bad, and then there's this huge gray in the middle, and that overlaps with a whole lot of other things that we do. And this is where I start to think about the other medications we use. So I think about the narcotics. I think about our current guidelines on chronic long-term pain management. So yes, it may help with chronic pain. The question becomes is, if we've got fairly clear guidelines out there that say that for folks who are taking more than 100 morphine equivalents of narcotics, that person's risk of death goes way up as that morphine equivalent goes up. If you combine that narcotic with a benzodiazepine, say Xanax, Klonopin, whatever, your risk goes up even further. But we don't have good data to say, well, if you're above 100 morphine equivalents, if I give you some marijuana with that, what is your risk? How much marijuana becomes a risk? If I smoke a little bit, does that help with my pain and therefore I don't need as much of my narcotics? And I think the difficulty for the docs on the outside world, kind of in a day-to-day sense, is what do I do with those folks that are on some pain medication? And great example, I've got a guy who's a pipe fitter. He's in his 60s. So this guy's had a couple surgeries on his back already. He spends all day picking up 50-pound, 60-pound, 80-pound chunks of metal and bolting them and welding them to other pieces of metal. This is what he does every day. He's done it every day since he was, 25. And what he wants from me is a few doses of Vicodin so that when he goes home at night, he can actually have sex with his wife so it doesn't hurt, because his back's killing him. But then the problem becomes is, okay, I've got him under that 100 milligram morphine equivalent, because I'm only giving him, a couple of Norcos a day. But what if I test him and he tests positive for marijuana because he uses the marijuana because it helps with the nausea from the Norco? Do I cut him off from his pain medicine and say, you got to stick with your marijuana? You pick. How do we gauge these? If he's above 100 milligram morphine equivalents, should I really say, no, you shouldn't be on the marijuana at that point? We don't have any kind of sense of guidelines on this. And then what are the risks? I have no way of testing for how much people are taking. If these things were to go to if marijuana were to become illegal, even medicinally, how do I track that? How do we track their pain medicine and then how much marijuana they're getting? I have other questions about would it ever eventually, if it's a prescription and I prescribe marijuana, can they use their flexible spending account money to pay for it? Does it hit your deductible? I think as providers, how do we challenge our peers on this? So when do I look at a colleague and say, I did a drug test on this patient, and they tested positive for marijuana, and they're on benzos and narcotics. When do I start to give my colleagues grief about what they're doing with patients? And how do we set guidelines on where that is? I mean, we have physicians within our institution that have been sanctioned or evaluated or looked at by medical staff because of inappropriate prescribing practices. And I mean this is a statewide institution. And the question is, how do we gauge that? What does that start to look like when we throw marijuana into that mix? How do we self-police? I had a 20-year-old come to see me. He's a fairly successful college student, did really, really well in high school, and he came in because he wanted to be evaluated for ADD. He had been evaluated in high school, and he had been evaluated, and the provider said, you don't have ADD, and they did not give him medications. Now he's really struggling with classes. He's having trouble getting through day to day. He's not doing well on his tests. Well, the long conversation ended up, yes, I'm drinking 5 to 8 drinks at a time, at least a couple days a week. And, oh, by the way, we're passing around the bowl every other day. Okay. So he was one where I had to have a real clear conversation with him about, maybe the pot and the alcohol are part of the issue here, and I shouldn't be putting Adderall in on top of this. The difficulty becomes is, we've been treating ADD for 25 years, close to 30 years now with stimulants. So we've got lots of folks in their 20s, 30s, 40s that are now on chronic amphetamine use. And I prescribe these medicines. I'm a primary care doc. We do this. But then I've got no legal mandate to test those folks. We don't do drug tests on our ADD folks as a general rule. So the question becomes is, should I be urine testing all of those folks and asking, are they taking pot? Well, if I did that on all my college students who are taking Adderall or Ritalin or Vyvanse, I'm going to get a lot of pot positive folks. I mean, at least a third of them. Okay. So how do we handle those? I think the difficulty with the chronic pain issues are around separating out what we think of as those horrible situations where the folks have metastatic cancers. They have some sort of end-stage disease and they are struggling with chronic pain, and we're okay with putting them on these really high doses, and very appropriately putting them on very high doses of narcotics to manage their pain, and maybe even letting them have a little pot because it makes them feel better or makes them feel comfortable or helps with the nausea. But the question is, there's this huge other group out there, outside the hospital, who are those non-cancer, chronic, modest level pain folks. And those are the ones that are really struggling to figure out how to do this and what this would look like. I'm only going to refer to one study, and it's a tiny one. This was a 1991 study called the Marijuana Carryover Effects for Aircraft Pilot Performance. And I love this study. This was actually, so a year and a half ago, the National Family Medicine Conference was done in Denver. So there were lots of tours of the dispensaries going on. And a bunch of the psychiatrists were talking about marijuana. And this study got brought up again by the psychiatrists. And it was a tiny study. It was only about 9 pilots who were commercial airline pilots. These are the folks that would fly our planes from New York to wherever. And they brought these pilots in, they put them on a simulator, and they said, fly. They flew the plane, the simulated plane, and they pulled them out and they handed them a joint. And they let them smoke their 20 milligrams of marijuana. And then they said, get back in the plane. And they watched their function at 4 hours, 8 hours, 12 hours, 24 hours, and 48 hours. And surprise, when they smoke pot and get in a plane, they don't fly as well. Okay? At 4 hours, they don't fly as well. At 8 hours, they don't fly as well. At 12 hours, they don't fly as well. At 24 hours, 7 of the pilots still had impairment. The problem was this. This was the real problem. At 24 hours, all but 1 of the pilots felt that they were perfectly fine to fly. So the issue is, at that 24-hour mark on this study, they said, look, we got a bunch of folks who self-assess at this point as being okay, but they can't pass what we would feel comfortable letting them fly on the simulator. So then when I go to counsel my patients on what are they doing and why are they doing poorly on their tests, right, I tell them about the pilot study, and I say, do we need to treat your ADD or do we need to address the marijuana? I'll stop there.
I was looking out at the audience and I felt like you all had the munchies. I'm watching all of you eat. I'm not a pot user. I guess I feel like I have to disclose that for some reason. I did use in high school once, and strangely, multiple times in 7th grade. Can you imagine that? And that was it. I haven't used since, or at least I didn't inhale, right? That's the... So I'm an there you go. I'm an oncologist and an ethicist, and so my comments are, you should keep that in mind. I have a very particular worldview. And I'm really just going to try in 5 minutes to raise a few questions with you. I wanted to refer also to this National Academy of Science review to which Sage referred, because it's clearly the most definitive work on outcomes for marijuana in the world of medicine, mental health, etc. And I mean, it's a really great work. It's really hard to get through because it involved something like 500 references or something. You can imagine a committee putting this together. And I just want to make one take-home point, which Sage has already made very well, and that is, despite the fact that marijuana is a plant that we have evidence that civilizations have been using for at least 5,000 years, and was an integral part of many civilizations and cultures, we have precious little medical evidence, at least definitive medical evidence, in most questions. So there are only a few questions, and I just sort of pulled out for your interest the areas where the report indicates that we have relatively conclusive or substantial evidence of either benefits or harms. So despite, hundreds and hundreds of studies, these are the sorts of things that we have. This is the motor vehicle data and so forth. And that's it. I filled that up with 2 slides. I did not include the few mental health outcomes to which I would also refer you. But this is important for clinician ethicists because the way we make clinical decisions is very similar in a sense to the way that we make ethical decisions, and that is we can't make ethical decisions in the absence of an understanding of medicine. And medicine, in one of its fundamental dimensions, involves a weighing of risks and benefits in an individual set of circumstances. So good clinicians are constantly thinking in an individual patient, given their circumstances, what are the risks, what are the potential harms, and what are the potential benefits, and how do we put strike some balance between those things. And when you have a research situation where you don't have very good information on any given clinical situation, one way or the other, it becomes very hard both clinically and ethically to help patients through those sorts of decisions. So some other examples where values come into tension with respect to marijuana use. We have professional obligations to advocate for patients' good. That would be one of our most important professional obligations. And yet states have the rights to regulate, and obligations really, to regulate substances that they deem harmful. So those values are going to come into tension in this discussion. Clinicians may have their own personal views or objections or beliefs about marijuana, and how would one balance those against the data that have been presented? And patients' desires to seek treatments, they may either believe or have experience with things that actually help them. So those are going to present values in tension as well. So I just bring those to your attention as a way of kind of framing ethical questions about this. This is a similar study which just sort of ranks the harms of various substances with which you're very familiar, with the most dangerous substance being alcohol, the comparator, which is a perfectly legal thing, although wasn't legal for a decade plus in the 1920s and early 1930s. But marijuana ranks way up there, with some studies suggesting that it's 500 to 1,000 times less dangerous overall for overall mortality than alcohol. And I think that has to be at least a fundamental aspect of the discussion that we have. And then the last thing I want to do, I just want to put a flag down in a couple of things. And this is wearing my ethics hat, I guess. And the reason why is I think it's important to ask why it is that we have so many sort of strong societal, cultural prejudices against this plant substance. And so I went back and did a lot of reading about that because I only knew a little bit about why it was. And the story, of course, is very complicated and far too complicated to go through in the next 2 to 3 minutes. But I wanted to just plant a flag in a couple of places. One of these is that the same lineage that gave us the sort of temperance movement, which led to the successful effort to pass prohibition in the 18th Amendment in 1920, the both religious and other societal views that were really strongly held and fundamental beliefs among much of society at the time, in particular Western Christian views, those views are still deeply embedded in the discussion. And so the lineage that led to the temperance movement and prohibition also, I think, we have to admit, color our views of marijuana as well. And it seems impossible to me to have a conversation, a rational, person-to-person conversation about this without starting to acknowledge some of these biases and prejudices. The other one is that the history of the prohibition of marijuana, at least in North America, in the U.S. in particular, is deeply caught up with the story of racism in America. So marijuana was used in Mexican culture for, again, 5,000 years at least. And there was a great deal of Mexican immigration, of course, in much of our history, but certainly in the late 19th century, early 20th century. And the Marijuana Tax Act of 1937, which was the first time that marijuana had been specifically prohibited by U.S. law, was clearly part of this racially motivated war on drugs. And I'm not going to read you this terrible quote from Harry Anslinger, who was the first commissioner of the Federal Bureau of Narcotics, which was the predecessor bureau of the DEA. I won't read it. Although one has to ask why he put all of these things together in one paragraph. But in any case, I'll just call to your attention, if you go back and read some of the history of this movement, these sorts of quotes were the norm, in fact, in that part of the movement. So, a really terrible stain on our history. But those set of prejudices around race and other things are really deeply part of our discussion. And I'm not trying to argue that it's necessarily as much of a part of the discussion right now, but I think that to ignore that part of the origin story of our views of marijuana would be to do a disservice to our intelligent discussion about the matter. And I'll turn it over to Tory Castor.
So good afternoon. The brownies are available on your way out. So, so I have the benefit, the privilege, the burden of kind of describing to you what's happening over from a legislative standpoint or a legal standpoint as it relates to the discussion we've had here today. And I'm very, very happy that my data tracks with yours, Sage, because I will readily admit I am definitely not an expert in this field. So if you'll just indulge me for half a minute or so, it's probably important for me to kind of describe to you a process before we get into the subject matter. As some of you may know, the Indiana General Assembly is in session at this moment, and they go through the end of April. And there are about 1,200 bills filed every session. Of those, there are about 362 that are still quote-unquote alive. In other words, they've made it through various requisite deadlines over at the General Assembly. And just maybe some touch points that I think are important to note. There were 33 bills filed as it relates to opioids. That is a huge number of bills to be filed on one subject matter. I think in the course of my 20 years over there, I've never seen that volume of bills related to one subject matter. The other important piece to note is there were 15 bills filed separate from the opioids on medical marijuana, cannabidiol, cannabis, hemp. Again, a very, very large number of bills on just one subject matter. Now, as I indicated, there are about 362 bills still alive of that at 1,200. There are 2 bills left dealing with medical marijuana. And the word I'm actually getting this, and this is changing by the moment, which is one of the reasons why I didn't want to have a slides up, because it truly is sort of very, very fluid over the last 24, 48 hours. But it looks as if there's going to be 1 bill left. And I have every reason to believe that this piece of legislation will be enacted. There's sort of a general rule of thumb in the General Assembly that you have, 1 or 2 authors and co-sponsors on a bill from each chamber, a couple from the House, a couple from the Senate. In this particular bill, if you were to actually call it up on the state's website, there are over 40 sponsors on the bill, which is a big indication that it's got lots of support. And the reason why it has so much support, there's a very, very vocal group of families that have been advocating for this type of legislation. You hear these horrible stories of these families, particularly with children, that have this sort of treatment-resistant epilepsy, and the only recourse they've found is through this medical marijuana or any product that contains cannabidiol. So it seems they seem to have targeted. Ironically, or not so ironically, there's probably a family in every member's district. And in fact, one of the sponsors in the Senate to this legislation actually has a child who suffers from this. So as you can imagine, he's a very passionate advocate for this legislation. So let's do this. Let's talk a little bit about the legislation and why IU Health got involved in this. I should start out to note that IU Health's involvement in this legislation, we've really been the only hospital system that has been vocal on this. We have not necessarily weighed in on the policy of whether or not they should authorize the use of, and I'm referring it as medical marijuana. We haven't said you should or shouldn't do it. Our point has been, look, we've got patients that are showing up in our facilities with these products, and right now, technically, we're obligated to confiscate it because, as you've heard earlier, it is a level 1 controlled substance. We also know that for many of these families, this really is sort of their only lifeline, and I don't think many of our providers want to be in the position of having to confiscate this product in some instances. So we've simply said, look, you need to give us an avenue whereby, one, we have at least civil and criminal immunity when these patients show up in our facilities, and to some degree, make sure that there's an avenue by which these patients can access this product. And I'll get into that in just a little bit. But the bill that's currently moving through session right now is House Bill 1148. And it defines cannabidiol, which is what you've heard discussed earlier, to include less than 0.3% THC, which, as you've heard, is that product that sort of creates that marijuana-like high. It also, what it does is establishes a registry for patients, caregivers, and providers to register with the state, either to be able to certify the use of the product or to be able to legally possess the product without risk of prosecution. So the Department of Health will be responsible for setting up this registry. It also, at our request, provides civil and criminal immunity for providers who do treat these patients. And I should note, the patient is limited to only those patients with treatment-resistant epilepsy. And that's generally defined as someone who has, and I'm gonna slaughter this again, Dravet syndrome, Lennox-Gastaut syndrome, or some sort of other epilepsy that the patient has where the provider has used at least 2 or more treatment modalities. Those have not worked, and so this is sort of their only recourse. So it's limited to just those types of patients. Only a board-certified physician in neurology that is licensed here in the state of Indiana can, in fact, provide the certification to allow this individual to access the product. Additionally, it does permit pharmacies to dispense the product. And this has been a little bit of a sticky wicket as we've been negotiating this piece of legislation, because one of our concerns from an IU Health standpoint is we are hearing from our pharmacist friends that it's very unlikely that they will actually dispense the product. Regardless of what the state law says, there's federal law out there that says this is a level 1 controlled substance, and they risk losing their DEA registration so that they can dispense controlled substances. So we've tried to emphasize to our policymakers that by essentially using pharmacies as the only modality to dispense this product, you're creating a bit of an unfair expectation in these patients that they're going to be able to access this product at the pharmacies. And most pharmacies that I've talked to, our pharmacists included, have indicated, until it's changed at the federal level, it's very unlikely that we're going to dispense this product. So what we have been able to do with that piece of legislation is include some language in there that says, essentially subject to federal law, you may dispense it. As you may or may not know, the Obama administration actually had a memo where essentially the DEA said, we're simply not going to enforce some of the federal requirements around the recreational use as well as the medicinal use of marijuana. The Trump administration has in fact signaled that they may reverse course on that, at least as it relates to the recreational use. I think the medicinal use is still in question. So there's language as it relates to pharmacies. The other piece of it is there is language that actually encourages research institutions to conduct pilot studies in this area, in the medicinal use of marijuana. So this is the legislation as it's moving through the General Assembly. I have every expectation, as I said, that I think we'll see legislation enacted, but we're still kind of meeting out some of the specifics. At this point, probably the biggest sort of sticking point is around this pharmacy debate. And there is a little bit of a battle between the provider community and the Prosecutors Association on the civil and criminal immunity. However, I think at least reading the tea leaves today, it seems to me that that language will stay in terms of protecting our providers. So that's sort of the state of play as it is right now. So stay tuned. Very much a fluid process, but I have every reason to see we'll see some legislation this year. So thank you.
So we're going to move into our question and answer session. And for those that are on the broadcast site, I'm going to pull up a phone number that you can text a question to. And I actually already have a question that has been asked to us from Arnett. And I think it relates to some of what Tory was just talking about. Any suggestions on patients who come from another state with legal marijuana and need care in our facilities? Steps that we can follow?
Well, I've asked that same question. And I'm trying to figure out how I answer it while I'm being taped. So I've.
Why does recording make lawyers so nervous? That's what I want to know.
I'll tell you offline. So I can at least tell you the way we've handled it at some of our institutions, which is to say the patient generally comes in, they have the product. In fact, we did have a situation where a patient came in, had the product, was coming across the state. The child had a seizure. They presented at Riley. They had this product, at least from the standpoint of the caretakers on call at the time. It appeared that they came about this product legitimately. I think the family may have actually been from Colorado, to be specific. But nonetheless, what ultimately happened in that particular situation was the family disclosed it and presented the product to the care team. The care team pretty much said, "Look, here in the state of Indiana, this is an illegal substance. We're going to step out of the room." And, should this still be here, we're going to have to confiscate it. And so the family, rightfully so, kept it sort of on their person, and that was that. The Prosecutors Association has told me, well, there's no way we're going to prosecute any of the providers as it relates to that. It's just not it's not a representation I can take to the bank. The law is the law as it is today, and I think we have an obligation to abide by it, but nonetheless, you also have to kind of take into account the fact that this truly is a lifeline for a lot of these families. So that's generally how we've handled it to date.
Hi, I'm Jenny Donaldson. I'm the pharmacist that works with the neurology teams over at Riley, so I'm neck deep involved. So regarding cannabidiol, our families are getting it via the hemp loophole when it is classified as a dietary supplement. Okay. So this is being shipped across state lines. This is available at least one natural food store here in the city. Oh, so how do you address that point when they say, no, I can get it? It is legal.
Well, so you say they're actually accessing the product. So the issue is families are now getting this through a legal loophole, and they're actually picking up this product as a dietary supplement, and they're presenting in our facilities with this product. Is that how you're? Yeah. I don't know if there's much from an IU Health standpoint that we can do in that regard. I think it's readily acknowledged that it is out there, and that we've got to figure out how to regulate it, which is why you see the legislation that you see today. Interestingly of note, and I think your question poses a broader issue, which has been a little bit of a debate at the General Assembly, you'll hear some individuals in law enforcement say, you might as well just legalize it completely, recreational or medicinal, because we can't sort of divine how it's being used and if it's being used for a medicinal purpose. I'm afraid I don't have an answer for you on that, other than the fact that this is sort of the conundrum we're in, and I suspect you'll see iterations of this, of how we regulate this product over time, but it's the state of affairs is where we are right now.
Just to follow up on that, so there are medications that are made with that CBD compound, not THC. And in particular, for example, for children with seizures, that was made and to be able to give them something that didn't have the THC component but still had the CBD for anti-seizures. So I would posit that physicians are the gatekeepers of knowledge for their patients. And so if someone came to you with something that was not classified as a drug, like a Botox that we didn't know, and they said, I'm going to eat this, and you had scientific knowledge that that is a snake venom that could paralyze them, you can give them, and you can correct me if I'm wrong, your understanding of scientific knowledge and incorporate that into, I don't know if it would be their electronic medical record, but yes, they're taking it without being liable. This is just like, okay, this is what I know of this.
Yep.
So I have a follow-up risk question on this. And my question is, if we are seeing more and more people nationally using these drugs in kids with seizures, and currently we would say we will not give that child that marijuana compound, are we now putting ourselves at risk if that child seizes and dies because we took away a treatment? I'm just asking, is there a flip side to that? And I don't need an answer.
Well, I don't have one. But what I can tell you is the issue of sort of the kind of the dietary supplement has come up in some of the conversations. And the way I understand the way it occurs, and there may be others here in the audience that have a better feel for this than I do, is that oftentimes, you know, if it's quote unquote a dietary supplement, oftentimes we will have the patients self-administer it to themselves. Now, certainly the provider has an obligation to the best of his or her ability to be aware of that so they can kind of figure out whether or not there are any interactions that might occur. One of the things we did account for in this piece of legislation, because I was concerned a little bit about the physician being in the role of administering this product, when you can't verify, quite honestly, if it's in fact what it is, that the patient has the obligation to self-administer, that we cannot be required to administer that product to the patient. That's probably as close as we can get in terms of protection, but you've uncovered a pretty big issue that I think we're going to have to kind of work through in future legislation.
So I have a question that came in through text. If a patient tells us they are using CBD or smoking marijuana, are we to document this in the EMR?
Wants to take that one?
I mean, the short answer is, in my office, yes. I mean, when I document a history, when I'm taking a history and physical, I teach all of my students. You ask your patients, what do they use? We talk about substance abuse. I ask whether they use cocaine. I ask whether they use marijuana. I think this is part of a good history. Again, this is protected information. I ask people about sex. I ask people about all sorts of behaviors. So would I encourage my students to document this? Yes, I would teach them to. Do I document it? Yes, I would document it.
Hi, I was wondering if there's any random controlled trials going on in the pediatric arena in terms of like pediatric neurology patients with the seizures and like CBD or...
That compound, I didn't check on this, but that compound I mentioned, and I don't know the trade name, is being tested. It was made, I think it's in phase 3 trials now. It is being tested on children for seizures with a high CBD compound.
We have synthetic, like in Marinol, I think is the drug that's synthetic. What's inhibiting more pharmaceutical companies from synthesizing the THC and the valuable other, from a scientific standpoint? And is there a difference between the use of the natural product and the synthetic?
I don't think that's the limiting factor. So I used to work for Pfizer, and this is not a good target to go after because, one, it looks like states all over the country are legalizing a free version that is a weed that you can't stop growing. And so the upside. That being said, it is interesting as states, I don't know if any of you have read Freakonomics, but that's kind of like natural studies that are done in society without our intending it being done. That's happening with marijuana now because states are passing all these different laws in different ways. And so in many states, lobbyists are getting their fingers in there. And so, for example, in West Virginia, they were on Friday voting on it to pass legalizing marijuana. People could grow the plants in their house. And they were like, no, wait, let's talk over the weekend. And then basically now it looks like you won't be able to grow plants. You'll have to buy it from set distributors, which will aid in the dosage, and you'll know what you're getting, but also people will be able to make money off it.
Okay, so I'm going to try to get around everybody. I have another one through text. Research shows marijuana influences the growing brain negatively through 25 years old or more. By using an under 25 for any purpose, is there research underway on how young brains are redirected to become addicted?
Yeah, so that is a very good point. So the take-homes for marijuana are, it is bad when you use it super heavily, which a lot of people do, and when you're very young. And so those are both true. I don't think the FDA is going to let us test, elementary school children, even vaping the substance. I mean, you could do mouse studies, but in the most extreme case, I see it following the lines of tobacco use, so you'd have to be over 18 or something. I will say that there was a paper that came out a few years ago about looking at this kind of uncontrolled study for states, comparing it to opioid use. For states that legalized marijuana use, there was a 25% reduction in opiate dependence, and roughly half that, about a 12% reduction in opioid death. So the idea of is marijuana a gateway drug, it seems to be almost the opposite, that people can use it instead of things like opioids.
Just parenthetically, the gateway drug hypothesis, which has been around for a very long time, is there's absolutely no good evidence that it serves as a gateway drug that I know of.
No, there's been some papers, it's mixed, but I've read more against it.
I've got a question about my current, was somebody else going to answer that? Okay. I've got a question about my current clinical practice, given that it's not legal yet. So just a few days ago, I had a patient who was an elderly lady with kind of intractable dizziness and vertigo from a neurologic disorder ask me if it was okay with me if she tried marijuana. And I gave what I think was this kind of wishy-washy answer. I'm sorry, I can't prescribe it to you. I don't have any objection to your trying this. And I really don't. I actually think, she's not driving. She's not at risk of imperiling anybody else. I think it's reasonable. I told her that there was not good evidence for this particular symptom, and I had no objection to her trying it. But I wonder, sort of, what guidance would you give? If I honestly believe it's a reasonable thing to try for an intractable symptom, I don't particularly want to break the law or document in my medical record that I have. What should I say, and what should I document?
I don't know if anyone up here has a perfect answer to that question. 'Cause I guess you raise a few things, Lexi. One would be, I can't imagine that it's illegal in any way to make a recommendation in the privacy of one's own clinical office. So as for the recommending part of that, I would say go ahead. I'm a cancer doctor, and I frequently have patients who ask if they can try various forms of marijuana and other related substances, and I tell them I have absolutely no objection. There's a sort of a more theoretical, ethical question, of course, about the patient's overall good, and because it's an illegal substance, are we encouraging them to be in sort of harm's way? I think I would come down on your exact answer, which is that if you don't have any medical reasons to believe it would be harmful to them, then and they have a safe way of obtaining it, that it's okay to sort of condone it.
I have a mixed feeling on this one, admittedly. My concern is in geriatrics, folks, we're doing everything we can to back them off of medications. There are so many of the meds that we would use every day, like Flexeril, like sleeping meds, like all sorts of things that we are now saying, if you're over 65, we really need to think about backing those things down because of your risk of fall, because of your risk of confusion, because of your risk of wandering. That risk benefit, I would have to say, given that we don't know what product you're getting, Given that there are all these varieties of marijuana that are out there now, we don't know, are you getting the super strong one? Are you getting one of the mild ones? Are you getting the one that was grown in my backyard, wild, in Indiana? That would be my concern. And how does she judge what makes sense and how much makes sense, and how does she know to dose? And then what other medicines is she on? Are those going to interact? That would be my fear. And again, it's an expression of fear without any good data.
I have a question, and I'm asking it from another perspective. So as a social worker in a hospital setting, and I work in the pediatrics unit, so I get a referral from a doctor or nurse, and I'm looking through the chart, and I see a documentation that this child is using, there's some marijuana or something, or THC levels. Then I go do a biopsychosocial assessment on the parents and find out they're giving the kid marijuana, even though medically, but it's not legal. So I'm obligated to call DCS.
You know what? So the question is, child, you're looking through the medical record as a social worker. Child is clearly using some sort of medical marijuana associated with some clinical diagnosis or not? Yes or no? Right. To report that to Department of Child Services. You know, actually, I can tell you.
We wondered what the basis of your sense that you were obligated to report was.
Yeah, I can.
Cheryl's going to respond.
Okay.
Hi, I'm Cheryl Remy-Hunt. I'm the director of the social work team at Riley. And she's right in that if you have a positive test, you have a problem. Because the statute says if you're exposed to an illicit substance, which it still is in Indiana, still is by federal law, so this is how I coach my team, and this is what I shared with senior leaders at Riley. So if we realize that we have patients, most of them are neurology patients that are disclosing to us that they're using around seizures, we as a department, and I don't think you're in my department, but as a department, which is a large department at Riley, we do not file. We've made a decision not to file on that, and I didn't get the blessing of senior leaders. They totally understood. We did this in conjunction with the director of pharmacy. We made a call that we would not file based on that. However, we also discussed, would we draw this level on this self-report? We discourage that. That's different than a child being exposed in utero during pregnancy and born with an exposure to. But if you have a test, if you have a positive test, it's a different story. If that came to me, I really don't know what my answer would be to one of my staff, based on, because during discussions with the pharmacists, they told us that they did not believe that this type of use with cannabis oil would produce a positive result from a test. Now, again, we're not researching that, we're not studying it, we don't know that for sure, but that's what we believe to be the case.
I actually have a follow-up question for you. So hold on, leave the mic. So I feel like this is driving physicians underground. So it sounds like it's almost as if you had to pretend you didn't read that. Would you, as a group, feel comfortable then telling the family, don't have edibles? It's not the same. You could overdose for your child. I mean, or is it
Sure.
something where you're just like, we have to pretend we didn't see that?
There are lots of things that we pretend like we don't hear, and that's just true every day for lots of different reasons and very thoughtful, mindful reasons. But yes, I think
I think the commentary about we don't know the dosage, we don't know what it looks like. We've heard stories, not just with kids, but with adults, about the candies and things that are available when people bring it from out of state. So for children in particular, that dosage would be very concerning. We do talk about that. This family that Tory referenced had spent $500 on a vial of what they described as cannabis oil. We didn't know for sure. We didn't test it. They had driven to purchase it. They felt like it was made based on specifically for this child. I don't know what they did to make that happen, but I think we would feel very comfortable being concerned about dosage and the effects and that kind of thing.
I'm so sorry, but this is all the time that we have today. I think we could probably go on with questions for a whole nother hour. But I want to thank our panelists, and again, thank you all for coming. Please remember, if you need credit for this event, to pick up one of the cards outside on the table and fill out the survey. Thank you.